Welcome to the EHJ Today 2016 here in Rome at the ESC. My name is Julia Steli. I'm a cardiologist at the University Hospital in Zurich. We're here to discuss the trial Marc II. With me is Professor John Greenwood. He's a professor and cardiologist at the University Hospital in Leeds, UK. John, you just presented the trial Marc II at the hotline session here at the ESC, and the results are also published simultaneously in JAMA. Can you tell us something about the rationale and the background of the study?
Okay, well, I think we're all aware that invasive coronary angiography is often used early in the diagnostic pathway of patients with suspected coronary artery disease, and that's despite international guidelines advocating the use of non-invasive imaging to streamline that approach. And indeed, studies have shown that if you look at patients with elective coronary angiography, perhaps up to 60% of those could have no evidence of obstructive disease at all, suggesting that perhaps some of those might be unnecessary. So the Marc II trial was a British Heart Foundation funded prospective multi-centre randomised controlled trial to evaluate 3 different diagnostic strategies in the investigation of patients with suspected coronary heart disease. And those 3 strategies were cardiovascular MR or myocardial perfusion scintigraphy versus the guidelines which were the most contemporary at the time of the study start, which was the UK NICE guidelines from 2010.
Oh, that's very interesting. So the design was that you had these 3 groups, and how did it then go on?
So the primary endpoint of the trial was unnecessary coronary angiography as defined by invasive FFR measurement. And so we randomised 1,200 patients in a 2-to-1 fashion across those 3 groups to see whether we could find any evidence of reduction in unnecessary coronary angiography by a functional imaging approach. We also had some safety endpoints built into the trial, so we were looking across the 3 groups at the rates of positive angiography, i.e. the disease detection rates, and we were also looking at the rates of major adverse cardiovascular events across the 3 arms as well.
Interesting. And what did you find?
So we found that if we used a CMR strategy compared to the UK NICE guidelines, that resulted in a highly statistically significant reduction in unnecessary coronary angiography. There was no difference between the CMR strategy and the myocardial perfusion scintigraphy arm, so both of them produced quite a dramatic effect in terms of reducing unnecessary coronary angiography. And importantly, that didn't appear to be at the penalty of lower disease detection rates, because positive rates of angiography were equal across the 3 arms, and there was no difference in MACE across the 3 arms either.
And how do you think these results will affect our daily clinical practice?
Well, we're all aware that many of the guidelines that we work with are formed by consensus opinion, expert opinion, and that actually quite a small percentage of them are underpinned by really high-level Class 1 evidence. So this was a trial now to actually challenge the current guidelines as they were, and to see whether a functional imaging approach could outperform the NICE guidelines in terms of what we might consider and patients might consider an important primary endpoint, which was unnecessary coronary angiography. So it would appear to advocate that more functional imaging, acting as a more effective gatekeeper for coronary angiography, would be a way to go. It might also suggest that some of our pretest likelihood models perhaps overestimate disease risk, and that using more refined models, more updated models, again, might reduce this drive to the catheter lab, where angiograms are obviously being undertaken and not finding any evidence of obstructive disease.
That's really very exciting data. Thank you very much for the interview, John.